సార్
అదే స్టార్ట్ చేద్దామా?
మీ ఇష్టం, డేవిడ్ ఇన్ఛార్జ్.
అదే రాణి మేడం కూడా ఫోన్ చేశాను. షీ విల్ ఆల్సో జాయిన్ నౌ. ఇంకెవరు ఉన్నారు?
ఏం మేడం, మీకు అందరం ముహూర్తాలు ఏమన్నా అడగండి. సరే సరే సరే, విల్ స్టార్ట్.
సార్
గుడ్ మార్నింగ్ ఆల్. టుడే Dr. Jakinabhoyana Srinivas is talking on BP targets, which number where. We all know that we are maintaining the BP target of MAP 65, which is a gold standard mean arterial pressure. Still, Dr. Jakinabhoyana wants to elaborate on what are the real targets of blood pressure to maintain the organ perfusion, pressure to maintain the vital organs perfusion. Now I request Dr. Jakinabhoyana will start the presentation on this topic.
Yeah, thank you, sir. And good morning, all. Today we will discuss on BP targets, which number where. So this is completely evidence-based medicine. Will follow. Next slide, sir. Mean arterial pressure is the driving pressure of any of tissue perfusion. But every organ is having an autoregulation, which is defined as the intrinsic ability of the organs to maintain a constant blood flow despite changes in the perfusion pressure. Because even when you are awake, when you are sleeping, when you are standing, when you are doing different functions, physical functions, also the changes in the pressure will be there. So, but there should be an auto-regulation mechanism to avoid the organ damage. Organ blood flow and cardiac output are usually independent of arterial blood pressure, except under extreme hypo or hypertension. Organ perfusion is the difference between the inflow pressures and the outflow pressures. Okay, next slide, please. Yeah. So, perfusion pressure for different organs, how we calculate? If you take a brain, mean arterial pressure and minus CVP or ICP. So usually why I have mentioned this here is a CVP or ICP. ICP is intracranial pressure is a main calculation, but sometimes what happens, this patient is on a high ventilator support with a PEEP of 20. So this CVP will be higher than the ICP. So in that condition, you have to take a CVP as a value. So mean arterial pressure minus CVP or ICP, and the diastolic blood pressure is a inflow pressure is a diastolic arterial blood pressure minus CVP or intrathoracic pressure. Kidney, coming to kidney perfusion, mean arterial pressure minus CVP or intra-abdominal pressure. The bowel, mean arterial pressure minus CVP or intra-abdominal pressure. So these are the perfusion pressures we have to be much careful. I will give an example. Why this ICP, CVP, ITP, IAP is important is you maintain a mean arterial pressure, as Dr. David has already mentioned that mean arterial pressure of the kidney of all the organ is 65. Suppose if it is 65. But here if the CVP or ICP is 20, but the perfusion pressure is only 45. So is that sufficient to the brain or not? We don't know. So we have some evidence on that. We look into that evidence. But in the kidneys, the mean arterial pressure is, suppose mean arterial pressure is 65 and the IAP, intra-abdominal pressure, is suppose 30. That means perfusion pressure to the kidney is only 35. Even though you are maintaining the mean arterial pressure of 65, the perfusion pressure to the kidney is less. So this we need to concentrate, because the mean arterial pressure, the perfusion pressure of the organ is influenced by the other factors also along with the mean arterial pressure. Next slide, sir. So in the BP targets, we'll see in the neurology, traumatic brain injury, SAH and ICH. Next slide. So we all know that the normal auto-regulation of the brain is from mean arterial pressure of 50 to 150 mmHg. That means if your mean arterial pressure is 55, the blood flow will be the same. And if the mean arterial pressure is around 130 or 140 or up to 150, the auto-regulation will be maintained and cerebral perfusion pressure will be maintained well. So, for this reason, your brain is normal, or the most of our patient's brain is normal. So 50 to 150 is a normal. But here in this, the auto-regulation has to be intact. So in a traumatic brain injury or ICH or ischemic stroke, the auto-regulation mechanism goes out. So there we need to know the targets. What are the targets? So when the auto-regulation mechanism is intact, there is no need to worry. 50 to 150 of mean arterial pressure, it will maintain well. So if you see here in the y-axis, one side there is a cerebral blood flow and a cerebral blood volume. As the cerebral blood volume is increasing, the resistance also is increases. So cerebral blood flow increases and cerebral resistance also increases. And but here, because of the auto regulation, perfusion pressure is maintained well. Next slide, sir. So TBI, traumatic brain injury guidelines. So maintaining systolic blood pressure of more than 110 to decrease mortality and improve outcome. The recommended CPP target value cerebral perfusion pressure is 50 to 60 mmHg. If it is, suppose if it is less than 50, the CPP value more dangerous, and even more than 60 also, or 70 is more dangerous. Why? Because if it's a, sir, previous slides, yeah. So if it is less than 50, the patient perfusion, the cerebral perfusion pressure, the blood will not flow, perfusion will not be good. If it is more than 70 cerebral perfusion pressure, then what happens is your there will be more perfusion and more edema happens. I'll give an example, short example. If your mean arterial pressure is 65 in a patient with traumatic brain injury, and if that ICP is 20, so that says that your your cerebral perfusion pressure is 45. Even though 65 of mean arterial pressure, if the cerebral perfusion pressure is 45, that means the brain is not getting adequate perfusion. So how do I know? I need to know the perfusion pressure only by monitoring a intracranial pressure monitoring. So how do I know intracranial pressure? Again, we need to monitor it. So monitoring of intracranial pressure is not going to improve the outcomes because it's a monitoring tool, but definitely you will know the what range of CPP you are how to maintain, because this is a very narrow range, 50 to 60 as per the guidelines. But if so the two, we can't predict the intracranial pressure without monitoring the ICP in our patients. Next slide, sir. So in a subarachnoid hemorrhage, rebleeding is associated with very high mortality and morbidity. 30% within 3 hours and nearly half within 6 hours of symptom onset. Early rebleeding is associated with worse prognosis compared with the delayed. Next slide. So here also we need some guideline in SAH. So between the time of SAH symptom onset and aneurysmal obliteration, blood pressure should be controlled to balance the risk of stroke, rebleeding, and maintenance of cerebral perfusion pressure. This is a class 1 evidence. So blood pressure control to reduce the risk of rebleeding not established, but a decrease in systolic blood pressure less than 160 is reasonable. Next slide, please. Yeah, previous slide, sir. Previous slide. Yeah. So here in a subarachnoid hemorrhage, there is also some evidence that if a patient is having a 210 of blood pressure, so don't straight away decrease the systolic blood pressure to less than 160. You can decrease the mean arterial pressure approximately 15% in the first 24 hours. And next, you try to decrease it to less than 160. That is reasonable in a patient with a subarachnoid hemorrhage. Next slide, sir. You take into the acute ischemic stroke. blood pressure less than 185 mmHg and their diastolic blood pressure less than 110 mmHg before IV thrombolytic is initiated for the next 24 hours. So when you are giving thrombolysis, if the blood pressure is less than 185 by 110, so that the bleeding chances will be less post thrombolysis. So this is also some evidence that it is not the only blood pressure variability. Like we all know that the glycemic variability, how we understand about the glycemic variability, blood pressure variability also increases the mortality and morbidity in the patients. Next slide, please. In a non-thrombolytic patients, a patient who is having a hypertensive patient having acute ischemic stroke presented after 8 hours or 24 or 10 hours. So his blood pressure is very high, like 210 by 100. So don't aggressively decrease the blood pressure in these patients. So in patients with the blood pressure less than 220 by 120, who did not receive IV thrombolysis, hypertension within the first 48 hours to 72 hours after an ischemic stroke is not effective to prevent death or dependency. So in this also, if a patient with acute ischemic stroke, early treatment of hypertension is indicated in some cases where acute coronary event, acute heart failure, aortic dissection, lowering blood pressure initially by 15% is probably safe. Excessive BP lowering can sometimes worsen cerebral ischemia. So you may think that the patient can have a heart failure worsening, but acute coronary event can worsen. But you may have a low perfusion, and ultimately you will have a brainless fellow who can have a good heart function. So we need to look, brain should be in the priority range. So that is most important in these patients. Next slide, please. So intracranial hemorrhage, elevated blood pressure, hematoma can cause hematoma expansion, low blood pressure, penumbra, hypoperfusion. So in ICH patient, systolic blood pressure between 150 and 220, acute lowering of systolic blood pressure to 140 is safe and it can be effective for improving functional outcome. So consider reduction of blood pressure with a continuous intravenous infusion free. So any patient other than SAH, intracranial bleeding is less than 140 is a standard of care in our patient. We need to decrease it. Next slide, please. So where do they get an evidence? This evidence we got from, there was an INTERACT trial 1 and the INTERACT trial 2 is the largest randomized trial. Almost approximately 3,000 patients with systolic blood pressure between 150 and 220 within 6 hours of intracranial hypertension. So 719 of 1382 participants, that is 52% receiving intense treatment. That means systolic blood pressure less than 140 within 1 hour of randomization for a duration of 7 days. So as soon as the patient comes with a 200, 250, whatever is the blood pressure, straight away decrease the blood pressure to 140, less than 140. And one more patient receiving a standard treatment less than 180 had a primary outcome of death or disability. So is statistically significant. Next slide, please. And secondary endpoints indicated significantly better functional recovery, the MRS scale, and better physical and mental quality of life from intense care treatment has a better quality of life in this. So there's a mortality, there is a trend towards a decreased mortality, and better has a physical and mental and quality of life, and MRS score will be better in a patients who decrease less than 140. So this is from the INTERACT 2 trial. We are a part of, when I was in the Apollo Hospital, myself was a part of this group, and INTERACT trial 2 was done in Apollo Hospitals, Hyderabad. And INTERACT 3 trial, since long time, the INTERACT 3 trial is going on, and I think trial has completed enrolled the numbers, and I think they are analyzing. Anytime we can get a good evidence from the INTERACT trial 3, which is one of the largest trial in the world with a lot of almost around 10,000 patients they have enrolled. Yeah, next slide, please. So intense BP lowering in acute cerebral hemorrhage. So attached trial, this attached trial showed no difference in the disability, but showed an increase in the renal adverse events within 7 days on the intense treatment arm. So no benefit of intense blood pressure lowering in the ICH. So here is between less than 140 or less than 180. So they did not show any difference. Next slide. And in fact, it has showed increase in renal adverse events within 7 days on the intense arm. So this is an association between the hyperacute stage blood pressure variability and outcome in patients with spontaneous intracerebral hemorrhage. So as I was mentioning that, it is not the glycemic control which is more important. In the similar way, blood pressure variability during the hyperacute. So here among consecutive patients with, 386 patients with ICH, among consecutive patients with ICH enrolled in FAST-MARK trial, BP were recorded by paramedics in the field and during the first 24 hours of the hospital course. BP was analyzed in a hyperacute period from 0 to 4 to 6 hours and in acute period from 0 to 24 to 26 hours. BPV was analyzed. So BPV during the hyperacute first minutes and hours after onset in patients with hereditary was independently associated with the poor functional outcome. Stabilization of BPV during this vulnerable period in the pre-hospital and early emergency department course is a potential therapeutic target for the clinical future trials. So this suggests that, so as soon as a patient comes to you, you have to monitor the patient, put an intra-arterial pressure monitoring, and you titrate with the intravenous antihypertensive medications and titrate these patients with the blood pressure less than 140 in the patients. And also there should not be more variability. Like now it is having a 220, then having a 140, and then going to 180. Then than that, I think 160, 170 also is okay. Then more variability. Similarly, what we see in the blood sugar control, 100, 180, 230, 400, like that. If the pressure is if the sugars are very high, that causes very high mortality and morbidity in the patients. Similar way, blood pressure fluctuations also give results. Next slide, sir. So before going into this cardiac failure, at the same time, I forgot to mention you that in the traumatic brain injury, the perfusion pressure of 50 to 60, we need to maintain. And specifically in a trauma patients and people are doing resuscitation with a low blood pressure, I think you need to look into these patients who has a traumatic brain injury. If they have a traumatic brain injury, I think those having a low blood pressure and resuscitating these patients will cause, you'll have a patient, good recovery of the patient will be good, but brain will not recover, and these patients will have a hypoxic brain injury, hypoperfusion brain injury with a normal organ function. So we need to be very cautious in such type of traumatic brain injury patients. Coming to the cardiac failure, a large RCT demonstrated that in those with increased cardiac risk, defined as age more than 75 years, established vascular disease, chronic renal disease, control of blood pressure to a goal systolic pressure of less than 120 mm was associated with a significant reduction in the incidence of heart failure and overall decrease in the cardiovascular death. So heart failure with reduced ejection fraction should consider a goal blood pressure reduction further. So usually in these patients with a reduced ejection fraction, we usually, even in a regular patient, he is mentioning about less than 120, we maintain around systolic blood pressure of around 90 to 100 in those patients with a reduced ejection fraction. But ideally, recommendation is approximately around 60 to 65 mmHg of mean arterial pressure, even in the reduced ejection fraction with the cardiac failure. So that's the reason why we need to maintain a 60 to 65 mm of HG even if the patient is having a reduced ejection fraction or a normal ejection fraction. Next slide, please. So cardiogenic shock, 60 to 65 mmHg gold standard. In a approximately around 90 systolic blood pressure of 90 mmHg is mandatory. Treat the underlying cause. Why? Because in these patients, actually cardiogenic shock, the blood pressure, if you are increasing the blood pressure to higher blood pressure, MAP or systolic blood pressure is very high. What happens is here, you need to increase the vasopressors. The vasopressors, if you increase the vasopressor, your afterload increases. Your afterload increases and there is more pressure on the heart again to pump it. The more pressure, again, there is a more increase of cardiac failure. So that's the reason why they say that 60 to 65 mmHg or a systolic blood pressure of more than 90. Here, there is a difference between the patient with a septic shock and a cardiogenic shock. The septic shock patient, see, you know that mean arterial pressure is diastolic pressure plus 1/3 of the pulse pressure. So here you will have a diastolic pressure of good. Sepsis, usually we see the diastolic pressure is low. That's the reason why 60 to 65 pressure of, we talk in terms of mean arterial pressure and the systolic blood pressure. But in a patient with a cardiogenic shock, you can have a mean arterial pressure, better diastolic pressure than the patients in a septic shock, because here there is a vasoconstricted state, and there in the sepsis is a vasodilated stage. Next slide, please. So coming to the abdominal perfusion pressure is equal to mean arterial pressure minus intra-abdominal pressure. Elevated intra-abdominal pressure reduces blood flow to the abdominal viscera. Higher mean arterial pressure may maintain abdominal organ perfusion when there is an increased intra-abdominal pressure. A target abdominal perfusion pressure of at least 60 mmHg improves survival from intra-abdominal hypertension and ACS. Patients with measured intra-abdominal pressure more than 25 mmHg usually develops ACS. And here, some calculations go like abdominal perfusion pressure is equal to mean arterial pressure minus 2 into intra-abdominal pressure. So abdominal pressure, intra-abdominal pressure, unless you measure the patient intra-abdominal pressure, you cannot identify the patient is having an intra-abdominal pressure. And the abdominal distension, and you identifying the abdominal distension and thinking of intra-abdominal pressure, I think by that time the pressure is almost more than 20. So we need to monitor whether the patient is having a high trauma patient or patient with abdominal pathology or required a lot of fluid resuscitation. These patients, intra-abdominal pressure monitoring is a worth, so that you will know how much to maintain the abdominal perfusion pressure than just seeing the abdominal girth or clinical evaluation in your patients. Next slide. Yeah. So in autoregulation, renal autoregulation, we know that the brain cerebral autoregulation is between 50 to 150. Here in the renal autoregulation, it is approximately around 100 to 180 is a renal autoregulation. Here these are normally is around 80 to 180. 160 is a normal autoregulation. If you see in this patient, this is a dotted line is a normal, is 80 to almost 160. But if you see the solid lines, there are two types of one city is between 100 to 180 is one, and one more is 100 to 120, which is very close. So there are two types of patients. Chronic hypertensive patient with normal renal function, they will have approximately autoregulation from 100 to 180. A normal chronic hypertension patient with a chronic renal disease will have from 100 to 120 as a autoregulation. So the patient with a chronic hypertension having a renal disease, the autoregulation is very close. So around 100 to 120 of a mean arterial pressure. Next slide, please. So renal function, most studied in patients with severe sepsis or septic shock. So creatinine clearance in septic shock patients whose baseline MAP below 60 was raised above using norepinephrine. Urine output and creatinine clearance, no benefit of by raising mean arterial pressure from 65 mmHg to 85 mmHg. Autoregulation threshold of kidneys may be closer to 65 than 80 mmHg. So in a patient with a sepsis or septic shock, there is a vasodilated condition. So in that, so why we have come to, even though there is a brain is having specific autoregulation, kidney is having separate autoregulation, and the liver is having separate autoregulation, abdominal perfusion pressure is having separate, abdomen is having separate autoregulation. So everything, the values are not the same, but most of them they have arrived is in sepsis. So the 65 mmHg is basically in sepsis. Sepsis, all the vasculature is paralyzed. It is all paralyzed and vasodilated stage. So autoregulation is lost in the body. So 65 mmHg should be good autoregulation for all the respective organs. So where the mean arterial pressure of 65 mmHg has come. So that might be the concept why this 65 number is very good, and whenever any intensivist asks, so in critical care head asks, calls, and what is a MAP? So he doesn't bother about the systolic and blood pressure and diastolic. That is a good thing. What is a MAP? MAP is most important because in a sepsis patients. Next slide, please. The liver plays a critical role in severe sepsis and septic shock for two reasons. Entire splanchnic circulation, which comprises 25% of the cardiac output, must pass through the liver. Gastrointestinal tract is thought to be a driver of multi-organ failure syndrome in sepsis. 90% of the body's reticuloendocrine system exists within the liver. The liver receives both arterial and venous blood flow. Mean arterial pressure of 65 to 70 is acceptable for both liver and bowel, but again depends on the intra-abdominal pressure, which is more important. Next slide, please. Bleeding patient. Aggressive fluid resuscitation in bleeding patient leads to additional hemorrhagic through soft clot dilution of clotting factors. At the best, literature suggests that small allocates of fluid, 100 to 200 ml, should be given to maintain the patient's systolic blood pressure between 80 to 90 mmHg. Uncontrolled hemorrhage with a traumatic brain injury prevention of secondary blood pressure, brain injury, less than 90 mm is associated with poor prognosis. So in these patients, you need to maintain either two things: systolic blood pressure more than 90 mmHg. The best is the the cerebral perfusion pressure between 50 to 60. Again, in such bleeding patient, difficult to measure the cerebral perfusion pressure. So at least maintain in these patients the systolic blood pressure more than 90 mmHg. Next slide, please. So high blood pressure versus low low blood pressure target in a patient with sepsis or septic shock patients. You know, sepsis spam study. In patient with septic shock, does a high mean arterial pressure compared to a low? Low means around 65 mmHg. Don't think low means less than 65. So open label, double blind randomized control studies, 29 sites in France, 76 patients, all septic, 65 to 70 mmHg, mean arterial pressure versus 80 to 85 mmHg. So less than 6 hours of vasopressor initiation is started. Next slide, please. Yeah. Targeting a mean pressure of 80 to 85 mmHg as compared with 65 to 70 in patient with septic shock undergoing resuscitation did not result in significant difference in the mortality at either 28 or 90 days. So this was the primary outcome differences. There is no difference. Next slide, please. So they have done a subgroup analysis. So in patients with chronic hypertension, the high target group had less AKI. Okay. And number needed to treat is 7.6. Significantly low requirement of renal replacement therapy from day 1 to 7. Number need to treat is 9.5. more arrhythmias in these patients, and though there is no mortality difference. So chronic hypertensive patients may have a better outcomes in this patient, in a sepsis and septic shock patients with a mean blood pressure target of 80 to 85. But there is a high risk of arrhythmias, and this is in a patient with a septic shock patient. It is very difficult for us to maintain a blood pressure of around 65 to 70 mean arterial pressure. Maintaining a 80 and 85, 80 to 85 mean arterial pressure in these septic shock patients is a very difficult task, and giving high vasopressors can cause a lot of arrhythmias, and again decreasing the hypoperfusion. These are the things can happen. This is my personal experience in these patients. Next slide. So optimal vasopressor titration, the high blood pressure versus low blood pressure targets for vasopressor therapy in the multi-center randomized trial. So multi-center, 11 academic hospitals in Canada and USA, open label. And here, what comparing 60 to 65 and 75 to 80 mean arterial pressure targets for fluid resuscitation hypotensive patient treated with vasopressors, expected to continue for at least 6 hours. The primary feasibility outcome was a difference between group difference in the mean arterial pressure during vasopressor therapy. Next slide, please. Here they found that subgroup analysis for hospital mortality, only there is a difference between is the patient's age favors low mean arterial pressure in the patient who is more than 75 years of age. Next slide, please. So among patients aged 75 years or older, low mean arterial pressure target was associated with reduced hospital mortality, but not in young patients. The risk of cardiac arrhythmias and hospital mortality were not different between lower and higher, but there is a more arrhythmias are higher, but not statistically significant with the higher mean arterial pressure group. But mortality, there is no difference. But definitely, in the age more than 75 years, you should not have a higher blood pressure targets. Next slide, please. Pooled analysis of higher versus lower blood pressure targets for vasopressor therapy, septic and septic shock vasodilatry. Individual patient data meta-analysis. Pooled analysis of individual data rather than aggregate data may improve quality of and type of analysis data. The aim was to understand the effects of the intervention in specific patient groups. Next slide, please. So all adult patients with shock, higher mean arterial pressure targets, lower mean arterial pressure targets, lower mean 60 to 65, higher means 80 to 85. The 28-day overall mortality in following subgroups: chronic hypertension, age, congestive heart failure, and duration of vasopressor therapy before enrollment. Next slide, sir. So from basically sepsis, PAM, and ovation, all the data were adjusted for trial effect. Next slide, sir. So in this, whether chronic hypertension or a congestive heart failure, there is no difference. But in the patient's hours on vasopressor before enrollment, like more than 7 hours, it favors a lower target. But there is no less than 6 hours patient on a vasopressor therapy. Whether if you are having high like 80 to 85 or 60 to 65 or 65 to 70, there's no difference less than 6 hours. But after 6 hours, you favor a mean arterial pressure of 65 mmHg, because higher blood pressure targets are going to have a more mortality in these patients. Next slide, please. Higher requires more amount of vasopressors, not associated with overall mortality difference among patients with less than 6 hours before randomization. Significantly higher among patients on vasopressors more than 6 hours before randomization. And older patients may be more vulnerable to vasopressor-induced adverse effects. Lower mean arterial pressure targets not associated with patient important adverse events even in any subgroup, including chronically hypertensive patients. Next slide, please. Surviving sepsis guidelines, even 2021, they say that the mean arterial pressure of more than 65 mmHg is the target. Next slide, please. So any potential beneficial effect of raising the mean arterial pressure target should be balanced with potentially undesired side effect from the vasoactive medications. future trials to determine optimal mean arterial pressure. The current recommendation of 65 mmHg during critical illness should be viewed with caution, as we all has gone through the many slides. So we know that we need to look into the disease, what is his background history, and what are the present disease, what are the complications patient is having, and look into the target, the mean arterial pressure, than just going and hitting the 65 mm of Hg. Next slide, please. So I have done my best to maintain all the recommended targets in your body, and still the patient says I am dying. So one size does not fit all. Application of individualized hemodynamic targets. That's the reason why Motan is training every week. 2 classes, one in critical care medicine and another is anesthesia. And we discuss our classes in our regular, and each individualized patient is very important, and we need to look into that targets and manage it. Why is this happening? Next slide, please. Why is this happening is because, see here, this is the highest one, is the mean arterial pressure. If you come into the critical point, PCC is the critical point where the pressure is approximately around 40 mmHg, and PMSP here is a low at the level of a capillary, which is around 20 mmHg. And next is the CVP. This here arterioles. So this is aorta, is at aorta, then arteries we are looking at the mean arterial pressure. Aorta and the mean arteries we are looking at the mean arterial pressure of 65. But arterioles levels we are looking at the mean arterial pressure of 40, and at the capillary level it is less than 20. Then the venues and veins and inferior vena cava comes. So we are looking at the target of the capillary level of around less than 20. But are we measuring the pressure at the capillary level? No. Even if your mean arterial pressure at the arteries and aorta is 65, but we don't know what is the perfusion pressure at the capillary level. But there are surrogate values where we discussed about the capillary pressures, like perfusion pressure in the brain, abdomen, liver, kidney, and all these things we have discussed. But ultimately, even if you are maintaining that capillary, that perfusion pressure at the organ level, but normal, at the capillary level, we don't know what is the perfusion happening, because there can be a bleeding, clotting, vasoconstriction, many mechanisms happening at the capillary level. Okay, so that's the reason why we need to maintain at least these targets to maintain a better outcome for our patients. Thank you all, and I welcome questions. Thank you. Over to David, sir.
Only questions, David.
David sir, thank you for a good description and చెప్తారు కదా సార్ ఆయన, అందుకోసమే ఓవర్ టు డేవిడ్ అన్నారు.
అంటే గుడ్ కాకుండా గుడ్ అని చెప్పాలా?
ఎంకరేజ్మెంట్ సార్, స్పీకర్ కి ఎంకరేజ్మెంట్ సార్.
అంటే ఇప్పుడు వన్ టాక్ మే లైక్డ్ బై సమ్ పీపుల్, మే నాట్ బి లైక్డ్ బై సమ్ పీపుల్. ఇఫ్ ఐ డోంట్ లైక్ దట్ డజంట్ మీన్ దట్ ఇట్ ఈస్ నాట్ గుడ్. అంతే కదా
సార్? ఓవర్ టు యు సార్, డేవిడ్ సార్.
సో వెరీ నైస్ అండ్ వెరీ ఎక్సలెంట్, ఎక్స్ట్రాడినరీ టాక్ అన్నా.
థాంక్యూ సార్.
సార్ అందుకు ఇంకొంచెం ఎక్కువ చెప్తున్నాను. సో మై క్వశ్చన్, కెన్ ఐ స్టార్ట్ విత్ మై క్వశ్చన్? ఆర్ yeah, what is the best drug to control the blood pressure in a traumatic brain injury? Because NTG is bad for traumatic brain injury, as all of you know that vasodilation that causes increased ICP. So as you said, the fluctuation means variability. The rapid fluctuations in blood pressure will increase the mortality. So what is the best drug to avoid this variability?
No, sir, usually now we are using labetalol for all patients, because it doesn't cause much bradycardia and easily titratable and available. So NTG anyway we are not using it. So labetalol is a choice, sir.
Okay. Any questions?
So
Satish sir, answer ko question ko den ko chet ettaru.
Sir, morning, sir.
Good morning, sir.
Cheppana.
Sir, Newer concepts in management of sepsis, MAP can be reduced to some 50 or 55. Even there is a role to add vasodilator. Can you comment or anything?
Sir, actually, the vasodilation effect of this one to improve the perfusion at the tissue level.
Yes,
So
sir.
you mean to the same, sir?
Yes, sir. Yeah. See, NTG can be used in sepsis
Yes.
when the lactate is not improving.
Sir. Sir, that actually what happens is, if you start using NTG at the level, so what we are measuring, sir, is, as I have shown you that slide, sir, previous slide, and enlarge it. Thank you, Mundu, sir. Sir, David, sir.
Yeah.
This slide. Sir, if you see into that, so what we are doing, we are giving NTG and improving the perfusion, trying to improve. But at the capillary level, sir, if it is less than 100 microns, there is no major influence by these drugs. Whether you are giving a vasopressors or whether you are giving vasodilators, there are no major influence. There the influence is basically the capillary injury, endothelial injury, the micro thrombosis, those effects are there. So here in this process, if you start using NTG for increasing the perfusion pressure, so that may cause a blood pressure crash and then have more problems, sir. That I have that concept. But any new recent evidence, sir? Satish, sir?
No, sir. Still, see, as per the Jane Vincent Lewis, I have undergone one talk. He clearly told that accept a MAP of around 50 or 55 and don't hesitate to start vasodilator when the lactate is mounting, despite your best management techniques that are applied or given in the sepsis management. It doesn't make any deleterious effect, and it might improve the lactate levels, which in turn improves the perfusion of the patient. But we haven't have any daring to start NTG as of now.
Sir, at the capillary level, I think if we gave it optimal ఇది ఉంది కదా సార్, SDF with optical visualization ఉంది కదా, అది ఉంటే కనుక I think that is one of the surrogate where we can see the capillary perfusion at the mucosa level, sir. I think అది ఉంటే the best for especially for a sepsis patients. So అది ఉన్నప్పుడు we can titrate, we can play with the mean arterial pressure, sir.
Thank you, sir.
Varalakshmi wants to talk something. Varalakshmi?
Yeah, please.
Sir, I wanted to ask post-clipping, post-coiling pressure targets, sir, SAH.
Subarachnoid hemorrhage. SAH post clipping. అది కష్టమే మేడం. అది బేసికలీ not higher targets. I think 160, less than 160 better అనుకుంటున్నాను.
అనుకున్నంత ఐ థింక్ అనకూడదు.
I'm not sure. మేడం మీరు చెప్పండి.
Srinivas?
చెప్పండి మేడం.
I think neurosurgeons during coiling, they definitely ask for low blood pressure, but once the coiling is done, you need to maintain normotension. What the patient's baseline blood pressure is, you are requested to maintain around that blood pressure, not too high, but around the baseline of that patient's blood pressure we need to maintain.
Post clipping.
Madam Varalakshmi, madam.
What about madam? I have a doubt. Madam is telling normal blood pressure. After clipping or coiling, also the chances of vasospasm is high. Then if you maintain the normal blood pressure, that worsen the vasospasm, no? Hello?
Vasospasm ki you always have like a nimodipine 6th hourly or 4th hourly, I think you give regularly for a week or 2 weeks. Nimodipine istu untaru. That's what we do to prevent vasospasm. If I'm right. Varalakshmi?
Even I forgot. Anybody
Sir,
knows?
if it is, unless BP goes to too low, they won't stop it. If it is marginally low also, we continue nimodipine. And if you need, you start a small dose of Norad.
Yeah, that's
That's
what
what
even
we are
post
doing. That's
clipping
what.
should be maintained around 140 BP to avoid vasospasm. I think. I forgot actually. Anybody knows?
Yeah, it's that is the what is there are two scenarios, sir. One scenario is where the patient is, you know the neurological status of the patient. That means patient is conscious, or you are able to assess the neurological status. Then in most of the cases, like you said, a BP of around 140 to 160 is what is recommended. So below that, again, there is a higher incidence of vasospasm. So we generally tend to give, intak mundu we used to give the triple H therapy, but now it is more of a euvolemia with slightly hypertension. So even if the blood pressure is 120, we tend to start noradrenaline to maintain it between around 140 to 160
Post clipping.
systolic.
Post clipping also.
Post clipping also. Now the problem starts when you cannot assess the neurological status, because then you don't know, because the autoregulation is hampered, you don't know. Generally what they say is if at a particular blood pressure target patient, at a particular blood pressure patient is developing symptoms or patient is becoming more drowsy, then you have to maintain above it. But in general, we use a target of about 140 to 160, sir, post clipping. So that is generally, I thought, at 120, 130 people will just leave it at that. But we are supposed to start some noradrenaline and keep it higher at 140 to 160 post clipping. But that is also very controversial. It is not in all patients. The problem is when you cannot assess the neurological status. That is when you cannot. You cannot prevent delayed cerebral ischemia or vasospasm. So then the target is actually not known. But routinely, at least 140 to 160.
Any questions?
దీనికి ఎనీ వే ఆఫ్ మెజరింగ్ మనకి ఎట్లయినా SH పేషెంట్స్ ఆఫ్టర్ క్లిప్పింగ్ దే డూ క్రేనియం దే విల్ కీప్ బ్యాక్ నో మేడం మామూలుగా
Yes, sir. అంటే క్లిప్పింగ్ ఆర్ కాయిలింగ్ దేని తర్వాతైనా ద సేమ్ సార్. మనకేమి ఇవ్వరు కదా, దే నాట్ క్రెనియాటమీ చేయరు కాబట్టి క్రెనియెక్టమీ చేయరు. సో ద థింగ్ ఇస్ బ్యాక్ ఇన్ ప్లేస్.
అంటే ఇది క్లిప్పింగ్ కి చేస్తారు కదా వాళ్ళు క్రెనియాటమీ.
క్రేనియాటమీ చేసిన క్రేనియెక్టమీ చేయరు. దే జనరలీ పుట్ ద ఫ్లాప్ బ్యాక్.
ఓకే ఓకే బికాజ్ అంటే మళ్ళీ దీనికి ఏమన్నా ఐసిపి మెజర్మెంట్స్ ఏమైనా చేయాలా అనేది అంతే.
అదే ఇట్ ఇస్ కాంట్రవర్షియల్ సార్. ఒకవేళ అది మెయింటైన్ చేసిన, ఒకవేళ బికాస్ ద థింగ్ హియర్ ఇస్ ఆన్ ది ఆపోజిట్ సైడ్. సో cerebral ischemia vasospasm అంటే మనకి ఎక్కువ వీఆర్ టార్గెటింగ్ హయ్యర్ ఫ్లోస్ కాబట్టి again how high is the question, sir, whether 140 to 160 is enough, or sometimes even when if a patient at 180 was doing better, when it came to 140, if the patient is worsening, then we tend to go higher and maintain 160, 170 also.
మనకి యూజువల్లీ ఇన్ SH పేషెంట్ వి మానిటర్ ద పర్ఫ్యూషన్ ప్రెషర్, అంటే ఇన్ ద సెన్స్ వి డూ విత్ డాప్లర్ కదా మన ఇది.
yes sir, transcranial doppler తో చేస్తే
transcranial diaphragm flows కదా. So is there any blood pressure targets by using doppler?
No sir, it will just give an indication about the severity of spasm.
But it tells us severity, but at the same time, if the flow is high, should we maintain a higher targets or mean arterial pressure? Because you know that there is a vasospasm, severe vasospasm is there.
Yes sir. There is no direct correlation, but generally that is what is done, sir. There is an attempt to increase the blood pressure in an attempt to at least increase the flow.
Yeah.
Sir, this slide you are telling about renal auto-regulation for hypertensive patient and CKD patients. So in a septic shock, the patient with hypertensive patient presented with septic shock, You said the auto regulation between 100 to 180, but
Mm.
whereas in a patient in septic shock, the target of MAP is 65. So it is beyond the auto regulation.
Mm.
So once fall beyond auto regulation, how the perfusions will maintain?
Sir, here we have looked into, this is about the auto regulation of the kidney. But is again is the sepsis is a different. We have seen looked into the other study saying that even in a kidney is also, if it is mean arterial pressure 65 or 80, did not have any difference in the outcomes. That is only the auto regulation, but again in the sepsis it changes.
Yeah,
Right.
because
So
of vasodilatation.
vasodilatation.
So once a patient with 65, there is no urine output. If a patient is MAP is increased up to 80, if there is a urine output,
Hmm.
what is your opinion on that? Can we maintain the MAP around 80?
Sir, అది ఇప్పుడు it can be for multiple reasons. Is this patient having an ATN ఉందా, లేకపోతే is it a fluid deficiency? ఇవి చూసుకొని, and is this patient having a chronic hypertensive patients? We see, అంటే మనం యూజువల్లీ ఓపీడీ చూడం కాబట్టి మనకు తెలియదు. So chronic hypertensive patients can have a blood pressure control. Chronic hypertensive patients can have a blood pressure uncontrolled. So uncontrolled blood pressure ఉన్నదనుకోండి, వాడి ఆటో రెగ్యులేషన్ షిఫ్ట్ కావచ్చు. కంట్రోల్ బ్లడ్ ప్రెషర్ విత్ chronic hypertensive, వాడి ఆటో రెగ్యులేషన్ షిఫ్ట్ కాకపోవచ్చు. So this is all we don't know if unless you are closely following that fellow. So 65 లో బ్లడ్ ప్రెషర్ maintain blood pressure, you decrease urine output, 80 mmHg urine output is increased. Yes, you can target 80, but at the same time look into the other things. Are you targeting that 80 mmHg with a higher increased amounts of vasopressors or patient arrhythmias? Other things also you look into it, and you individualize for that patient.
Yes, right, sir. Sir, any questions? Mohan Maharaj sir, Mohan Rao. Hello.
హలో సార్
ప్రజెస్ట్ కొంచెం అలవాటు తక్కువ సార్.
రిగార్డింగ్
మాకు మేము మెయింటైన్ చేయం కదా సార్, ఐసీపీ ప్రెషర్లు అలాంటివి మేము మెయింటైన్ చేయం కదా, మాకు తెలియదు ఎక్కువ.
అది సార్.
శ్రీను
సార్ చెప్పండి.
అదే ఫర్ మానిటరింగ్ ఆఫ్ బీపీ విచ్ వన్ యూ ప్రిఫర్, వెదర్ రేడియల్ వన్ ఆర్ ఫెమరల్ ఆర్టరీల్ వన్?
So basically, if a patient vasopressor requirement is high, it's better. Ideally, there is no ideal, sir. The best is, and na experience prakaram ade femoral is a better one, because radial low, when there is a high requirements of vasopressors are there, so usually it will dampen faster, and maintenance also is a difficult thing. So femoral usually మేము in Ramchandralo ఉన్నప్పుడు almost every patient in septic shock will have only femoral catheter arterial monitoring. But later we have, once you come into the practice, we are putting radials, and most of the now we are doing radial only. So
that case, to prevent the infection, axillary is the best one.
Axillary more than 40 to 70 hours can't keep, David, I think. Thrombosis అయిపోతుంది.
మీరేం చేస్తారు?
Actually femoral sir, actually last 3 years back they did study in same when patients requiring high inotropes, they compared the radial and femoral for the same patient, they monitored. So only infection part is means more with femoral, but other than it gives the accurate blood pressure, and we can titrate inotropes also compared to radial.
Even the difference between the radial and femoral is around 20 mmHg.
Yes.
Systolic.
Also, the patients, if you suppose atherosclerosis, more chance of vasospasms, dampening more with radial arteries.
Yeah.
Regarding the
Sir,
మాట్లాడండి
sir.
ఏం లేదు. కానీ ఏదో చెప్తున్నారు కంపెనీస్.
regarding the post clipping, sir, during the intraoperative, after placement of the clipping, some of the neurosurgeons, they will ask anesthetist to bring the blood pressure to more than 180, 200 to see the patency of the clipping. After that, as Varalakshmi has told that we have to keep around 140 to 150 like that, with my knowledge. Regarding the nimodipine, when patient is developing hypotension, we can off the dose. I think 60 mg you are giving na, instead of that 30 mg we can give. But tell that to continue the same nimodipine.
డేవిడ్, అదర్ దాన్ దిస్ టాపిక్ ఏదైనా అడగచ్చా?
అడగండి సార్.
సరే, అయితే ఏం లేదు. జక్కినా ఉన్నాడు కదా ఎక్స్పర్ట్, సతీష్ ఉన్నాడా మన సికింద్రాబాద్?
చెప్పండి.
ఉన్నాడు.
ఒక పేషెంట్ ఒక 1 week బ్యాక్ పేషెంట్ ఎక్కువ పెట్టాం. సో ఆ పేషెంట్ నుంచి కొంచెం క్వరీస్ ఉన్నాయి ఇప్పుడు మాకంటే. కంటిన్యూస్ గా పేషెంట్ మధ్యలో చాలా ఇష్యూస్ ఉన్నాయి. ఏఆర్డిఎస్, ఐసీడీలు వేసాము, మళ్ళీ బ్లాక్ అయింది, మళ్ళీ ఐసీడీ మార్చాము. ఇప్పుడు కంటిన్యూస్ 3 days నుంచి ఫీవర్ వస్తుంది. అండ్ ఇప్పుడు ఏంటంటే ఇష్యూ మెయిన్ గా అది కాదు, బిలిరూబిన్ ఇస్ రైజింగ్ వెరీ ఫాస్ట్ వితౌట్ ఎనీ అదర్ అబ్నార్మాలిటీస్. సో 2 క్యాన్లర్స్ దగ్గర ఉన్నాయేమో చూసాము. డిస్టెన్స్ 10 centimeters ఉందా ఎక్కువే ఉంది అల్ట్రాసౌండ్ రేడియోస్ చూపిస్తుంటే. బట్ దగ్గర ఉందని అనుకుంటున్నారు. స్టిల్ హిమోలైసిస్ ఏమో అని. ఆర్బిసిస్ యూరిన్ లో ఉంది. సో మిగిలిన ఆ పారామీటర్స్ అన్ని బాగానే ఉన్నాయి. ప్రజెంట్ కి అయితే ఇన్ఫెక్షన్ ఉంది కాబట్టి ఫైబ్రినోజన్ కొంచెం పెరుగుతుంది, ఎల్డిహెచ్ పెరుగుతుంది, డబ్ల్యూఎస్పీ తగ్గింది, ఇప్పుడు క్రియాటినిన్ నార్మల్ ఉందంతా ఉంది. కానీ బట్ వాట్ ఈస్ కుడ్ బి ద రీజన్ ఫర్ కొలెస్ట్రాసిస్ అని అనుకున్నాం. కానీ బట్ బిలిరూబిన్ ఎంత ఎక్కువ అవుతుంది, నిన్నటికి ఇప్పటికి ఆల్మోస్ట్ 3 రోజుల నుంచి పెరుగుతూ ఉంది. సో వాట్ ఎనీథింగ్ కెన్ బి డన్?
మోస్ట్లీ ఇట్ ఈస్ హీమోలైసిస్ నో
అని అనుకుంటున్నాం. దాన్ని ఏం చేయాలి? అల్ట్రాసౌండ్ పర్వాలేదు, ఓన్లీ ఫ్యాటీ లివర్ తప్ప ఏమీ లేదు.
LDH levels?
ఎనీ గాల్ బ్లాడర్
ఏం లేదు.
గాల్ బ్లాడర్ పెరికోలిసిస్టిక్ ఎడిమా గానీ
అది ఇవ్వలేదు, మళ్ళీ అడగాలి ఈరోజు.
ఒకసారి చూడండి. గాల్ బ్లాడర్ వాల్ థిక్నెస్ గానీ
అది మళ్ళీ అడుగుతాను.
ఇండైరెక్ట్ బిలిరూబిన్ అండ్ ఎల్డిహెచ్.
ఎల్డిహెచ్ ఎంత ఉంది? 900. ఒకసారి ఇది బ్రదర్, ఎల్డిహెచ్ ఎంత?
LDH 600. LDH 600. That
కాదు మోహన్ రావు పెరిగింది. 600 నుంచి 911 వచ్చింది.
అదే 900